Just, just one sec. Can everyone see my screen?
Yeah, it's visible.
Thank you, sir. On this onset, I would like to thank AIS and Alcon for giving me this opportunity. So today, let's decode an unhappy 2020 patient. All right. So now all of us had cases where we have done a perfect surgery. The surgery's gone perfect well, and the lens implantation, everything was bang on the target. And the next day, when you see the patient, even before the patient talks, you will say, "No, don't worry. You're most welcome." And suddenly the patient looks at you in a very explanatory this one, and then he says, "No, doctor, I still have a lot of glare, halos, and so on and so forth." Now, how do we turn these frowns into smiles? So one of the first thing is to prevent it. And all the speakers, Dr. Bala, Dr. Samresh, Dr. Sandeep, have wonderfully covered in detail. So I'll just go briefly touch on the topics. One is choosing the right patient. Now, how do we choose the right patient? We need certain basic equipments. First and foremost is a detailed slit lamp examination is very, very crucial to rule out any kind of abnormality. And once you've done that, you've won half the battle. So make sure you look at the tear film and also look at the pupil size. Photopic, keep a cutoff of 3 millimeters and a scotopic of 5 millimeters. Always look at angle alpha, keep it less than 0.6 millimeters. And in terms of biometry, always go for a optical biometry. It's especially when you're going for these premium lenses. And all of this, I'm talking about a trifocal lens specifically. And the other point is, let's say if you're not able to use the biometric, at least you have to use an immersion. Please do not use a contact method. Now, you need to assess the cornea also to look for any high order aberrations. We usually keep a cutoff of less than 0.5. And OCT or macular OCT is nowadays a must for any cataract surgery, not just a premium lens, because sometimes you can easily miss out the subtle changes of epiretinal membrane, which when you do your regular fundus, you can somehow miss it. Yeah. Now, when we look at formulas, we have a lot of formulas in the market right now. But if you just ask me, can you just tell me one formula which works most of the time? I think simply just go with the Barrett's Universal 2 formula. Or if you can have hands on the TK formula, then that's fantastic, even better, which will work for most scenarios. Now, the 3 C's is extremely important. Counseling. You really need to sit with your patients, sit down and talk to them, make them to understand, and make sure that you have more realistic expectations. One of the tricks when how I counsel my trifocal patient is basically what I say is these lenses have, really cutting edge technology. They have these rings around the rings on these lenses, because of which when you see the light, you see rings around. That means the lens is working really well. But over time, as the time goes, it becomes fader and fader. These few lines make us very, very, huge impact. And the patient post-surgery, when he sees these rings around the light, he's very happy. He'll not be a complaint. Oh, good, my lens is working. So he'll be happy. So these small tips, I feel you really need to talk to the patient. And by doing so, the patient becomes more comfortable. The next thing is when you're counseling, you really understand what his needs, because a lot of patients, they say, okay, I want all distances, distance, intermediate, and near. And in such patients, trifocals do fantastic. And in certain patients are like not so particular about the near vision. Once in a while, wearing glasses, they're okay with, but distance and intermediate, like computer or cooking, they're very particular. They don't want to wear glasses. That time EDOF lenses do really well. Now, after doing certain testing, there'll be scenarios where you have these borderline cases where angle alpha is borderline or the high order aberration is borderline. In such scenarios, actually EDOF lenses do really well. And in terms of vivity, you can even push in certain retina abnormalities and other things also. It has really opened up a lot of new opportunities for different patients and doctors. And definitely, like this one, in terms of astigmatism, anything more than 0.5, please do not put a regular trifocal lenses. Always go for a toric one. This I mentioned in all my talks. In all my toric patients, I implant a CTR. As you can see, I'm implanting a CTR under irrigation. The trailing part of the CTR, I always hold it with a microforceps and implant it into the bag. That way, you're rest assured that it doesn't slip into the sulcus. Now, here you can see the intraoperative OCT of just an implanted lens. Now you can see a huge gap between the posterior capsule and the lens. This is one of the reasons why there's a higher chance of rotation during the early postoperative period. Now, when you implant a CTR, it expands the bag and brings the anterior posterior capsule closer together and increases the contact between the lens and the bag, thus preventing the early rotation, the rotation of the lens during the early postoperative period. Here you can see an image of the post-implantation of the CTR. There's a beautiful contact between the posterior capsule and the lens. Other than just polishing the posterior capsule, please do not forget to polish the anterior capsule also in these premium lenses, because any kind of a fibrosis or PCO can really significantly affect the visual quality in these kind of lenses. Always also align your toric lenses perfectly. If you have a markerless system, fantastic. It makes life so much more easier and much more accurate. So when you compare a marker versus markerless system, actually in terms of quantity, absolutely no difference. But when we look at the quality of vision, there is a significant difference, especially when you're going with a toric trifocal lens. And several studies have published this. Now let's go over a few cases. So here's a patient who had 20/20 vision for distance intermediate linear, but extremely annoyed with his vision. So when we look at the visual quality, there's something arising from the cornea or the surface of the eye. So we looked at the tear film. As you can see, there's a significant abnormality. So we put the patient on dry eye treatment, and this is how we improved. And his quality of vision also improved fantastically. So now coming to the next case here, again, a post multifocal patient had a lot of glare and halos. And this is how his quality of vision was. It was pretty bad. And when we looked closer, actually, there was decentration of the lens. Sometimes just a good slit lamp examination itself can pick up so many things. And, whenever you do face some problems, do not try to blame on something else. Always start with the basics and then keep, going ahead with your investigation. Now, here's one more patient who post-surgery had a lot of issues in terms of visual quality. Basically, the patient had posterior capsular opacification. The early PCO also can disturb these trifocal lenses. So do not shy away from doing a YAG. It will improve significantly. The visual quality will improve significantly. But with the current generation of lenses, the chances of PCO are extremely rare. So here's the last patient. Basically, it's again post-trifocal lens. Patient's really unhappy. And when you look closer, basically patient is left out with the residual astigmatism. So what happened here? How did we miss this? So what happened is the doctor ordered a trifocal toric lens, but the company by mistake sent a regular trifocal lens, and the doctor did not check it. So it is very important to, even though if you have ordered it personally for that patient, always check the lens, not just once. You need to have 3 or 4 times, multiple checkpoints before you implant lens, not just trifocal, any monofocal lens also. Make sure you have multiple checkpoints before you implant lens. So to summarize, how do we prevent a 20/20 unhappy patient first is always make sure you choose the right patient. Counseling is very, very important. If you, if I put an unhappy patient into an equation, unhappiness is equal to expectation divided by reality. If the patient's expectation is more realistic, no matter what the outcome is, you're rest assured the patient will be happy. Avoid extremely demanding patients. Always have a closer look for any abnormality. And a good practice does not just mean having a lot of patients. You need to have a lot of patients too. Whenever you do face any issue, please don't be impulsive. Always sit back, analyze the situation, come to a diagnosis, and then think of a solution. Lastly, I like to say, always keep your happy patients close, but your unhappy patients closer. Make sure you see your unhappy patients more often, and you need to reassure him that you will be with him till the time he is happy. Thank you for your time.
Thank you, Naren. Very useful tips, and I think